Hi, fellow clinicians. This is Professor Reis. I have the privilege of working with you and teaching you the tools of being a clinician. I particularly wanted to provide you with this video so that you would feel that your hand was being held as you were starting to understand what is depression. Depression is under the category of mood disorders. If you look at the title of your chapter, it's called Mood Disorders. If you would please have before you 3 sets of materials that are on Blackboard: the supplemental notes, the assignment that you need to do, and the case. What I'd like to do is ask you, if you have not yet looked at the supplemental notes and you have not yet read the textbook, you should stop the video now. Do that so you can have a context. My video is supplementary to those materials. It is not in lieu of. So please follow this order because that way the material will be much more available to you. If we look at unipolar, uni means one, right? Okay, so we're talking about a kind of depression that, for the purposes of this assignment, in this part of the course, we are focused in on 2 types of depression: either major depressive disorder or dysthymia. What you saw when you looked at the Gretchen case study in terms of panic attacks, or whether you did the other case study in terms of generalized anxiety with Irene, is that we have to pay attention to the number of symptoms and the kinds of symptoms that we have. You might recognize yourself as having some of these symptoms. It often happens when you take a course like abnormal psychology. Rest assured that you don't have the knowledge or the experience to be able to diagnose yourself. Okay, everybody tries to, but try to resist that urge. When we look at the 2 kinds of depression here that are on your sheet, we're talking about major depressive or we're talking about dysthymia. Your job in looking at page 203 of your textbook is to look at the symptoms that make up major depressive disorder. Okay, and you'll see that you have to have 5 of them. But what's crucially important is absolutely no one can get this diagnosis unless, of course, they satisfy one or the second, 1 or 2 of these types of symptoms. The first being that it's pervasive. It's not just you wake up hard and that you bounce back later. You pretty much stay in a state of struggling with depression. And what is that state? That relates to the symptoms that are on this sheet that we'll be talking about in a few minutes. The second is things that would give you joy no longer give you joy. Like yours truly, I love watching LeBron play basketball. Okay, if you saw me in class twice a week, you would have to listen to me chirping, chirp, 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 about how wonderful LeBron is. And some of you in sports would have your own kinds of favorites. If all of a sudden someone said to me, oh, LeBron is on tonight, or better yet, Dr. Reis, LeBron is going to practice at Baruch College, which, by the way, he often does practice here, and I would show no interest in being there or seeing him. That would be out of character. So what would one time give you great joy now no longer gives you great joy is a fundamental change, okay? So in order to get major depressive disorder, you have to either have that pervasiveness of depression or you have to have experienced great joy, but that joy is no longer something that you are able to experience. And then if you look at the second page of the supplemental materials, it gives you a list of the different symptoms that make up the second type of depression, which is dysthymia. So what you're doing here is you're learning how to use the Bible, the Diagnostic Statistical Manual, that helps us to figure out, as I listen to my clients talk about what's happening in their life, that they have a loss of appetite, that they feel particularly worthless, that they're having trouble eating, as we said, or they're eating everything, either extreme. I, as a clinician, have learned what these symptoms are. As your teacher, I'm trying to teach you those symptoms in what I perceive to be an interesting way, with looking at cases and leading you through the book. So it's not about memorization. It wouldn't be about that if you had me twice a week either. It's really starting to get an intuitive feed as to what these symptoms are. So back to the unipolar. Two types. Is it major depressive disorder, which obviously says major, so that's like a big type of depression? Or is it a dysthymia kind of depression, which in the before DSM-5 we call just a chronic state of depression? When DSM-5 came along, they renamed it. They called it persistent depressive disorder, which is why I've made that bridge in the second page of the supplemental notes to teaching you what is in fact going on there. Now, the other part of depression disorders is not everybody is unipolar. Not everybody falls into the category of just the lows, exhibiting a certain number of symptoms that your book will go in further elaboration. Some people fall into the category of bipolar depressions. Okay, when you hear the word bipolar, nobody ever says depression. They just say bipolar, as if it's one category. It isn't. It's three categories: bipolar 1, bipolar 2, or something that we call cyclothymic. If you're on the third page of the supplemental notes, you'll see all three of those things listed. The distinguishing factor between bipolars that are listed here and the unipolars is the word bi, which means you have the lows of depression like you have with the unipolar, which you could fall into the category of not only having a major depressive disorder or having that persistent issue that I spoke about in a few seconds ago. But the thing about bipolars is that you have the highs. You have what I described for you in your notes on the fourth page. I listed for you the mnemonic for keeping track of what it means to have the highs. As a clinician, we use the word mania to talk about the highs. And the best acronym is the word DIG, D-I-G, FAST, F-A-S-T. And if you look at your page in the notes, you'll see that there are 7 symptoms that make up mania. Everybody who has bipolar issues struggles with mania. That is the distinguishing factor between mania, between bipolars and unipolar. There's no issue of mania. There's only the low, there's no high. With bipolars, you got to keep track of what type of mania you have. So if you have bipolar 1, you have what we call a strong, intense state of mania. This is where experience is the best teacher, and where I want you to feel like I'm holding your hand to make sense of this. All mania is the word dig fast. It's all 7 of those symptoms. People, of course, don't fall into all 7 of those symptoms. If you have full-blown mania, it doesn't mean that you have 5 or 6 or 3 or 4. We don't care about the number of symptoms that you have in order to have full-blown mania. What we care about is the intensity, all right? That if you were in an emergency room or if a client came in, all right, it would be no question in your mind that they are experiencing full-blown mania. Hypo, less mania, H-Y-P-O, mania, is the difference between bipolar 1 and bipolar 2. The people with bipolar 1 have the highs of full-blown mania, and they have the lows, which makes up, you're right, major depressive disorder. The people with bipolar 2 have the lows, which is the major depressive disorder, but they have a state of mania that's called hypomania. It means it's less intensity, and therefore difficult to diagnose and very easy for a client to refute, a client at intake not to really share that kind of information, it might not be too different from who they are. In other words, if one of the symptoms is extreme talkativeness, this person never shuts up. But what we're talking about when we talk about mania in terms of talkativeness, we are talking about pressed speech. You can't get a word in edgewise. A person displaying that kind of talkativeness, as the listener, you almost want to breathe for them. Okay? In our class, you are going to be looking at cases. Now, I gave you the buddy case, right? And I made the assignment be that you need to rewrite the case so that buddy meets the criteria for bipolar 2. Right now, buddy meets the criteria for bipolar 1. So you need to sort out what that difference is, and I'm giving you a huge hint. It has to do with the level of intensity of the mania. So when you write about it, you need to show me what that level of intensity is. And before you do that, you need to find in this case how it is that in this case the level of intensity matches full-blown mania. So the interesting thing for me as your teacher is that it's a bunch of steps. And I think we can, as a class, be a great community of support to each other by using the class discussion to explore, not to talk about the assignment because I need to assess you separately, but to explore these distinctions between full-blown mania and what I'm now trying to teach you about in terms of hypomania, which is a less kind of mania. Now, if we have bipolar 1, which is depression, major depressive disorder, and full-blown mania, then we have bipolar 2, and bipolar 2 is major depressive disorder again, but hypomania. We now have a third type of bipolar, which is cyclothymic. So if we're looking at this third type, it has to be something different. Okay, so it can't be major depressive disorder and hypomania, because if it was, slow it down, look at the notes. If we had major depressive disorder and we had hypomania, we already know, thank you very much, that that would be bipolar 2. So if we have somebody else who has the highs and the lows of full-blown mania, well, hell, that can't be cyclothymic because Reis just told me that that is bipolar 1. So what is this beast that's called cyclothymic mood disorders that's underneath bipolar? Well, that beast is something that's similar to dysthymia, okay, or that persistent type of depression and hypomania. Okay, so that's the reason why we need that third type there. So if we go now to the assignment sheet, and I want you to note that the assignment is due on Saturday, March 26th. You'll see that the first thing that you need to do is to read the buddy case. Okay, and you have to tell me how it is that he meets the bipolar 1 diagnosis. The second thing you have to do is change the case. Now you're going to want to know how long is the change of the case. It's not an issue of the length. It's an issue of specificity. What is it that you change that makes Buddy have a bipolar 2 diagnosis? That's what I want to see. I'm probably looking at something that is roughly about 6 to 8 to 10 sentences to give you a ballpark expectation. Then your third task on this assignment is what changes would you make in the same Buddy case to make Buddy meet cyclothymic disorder? So the point of this assignment is to really give you an opportunity to generalize what I'm presenting in the video what I've shared in the notes, what you've been reading, to actually carry that out with the buddy case that I have gotten. So that's task 1, 2, and 3. With task number 4, you are to answer the question that I've posed. Okay? With task number 5, you're going to a specific case in the textbook. I gave you the page numbers for Katie. I want you to tell me what type of depression, Katie is experiencing, and I want you to support your answer by using that matching system that I taught you with the grid that you did with the subsection A assignment. So when you put it in a grid, on one side you put details from the case of Katie, and on the other side you put the DSM. Please, please make sure you only put those details that match the DSM. Some of you last time gave me the kitchen sink about the case. I don't want the kitchen sink. The cool part, the neat part about being a clinician is seeing that tree through that huge forest. We have to pay attention to the specific symptoms. If we throw in the kitchen sink, it's very easy to lose track of what you're looking for. So the idea of the grid is to help teach you the symptoms without memorization, and to help you in a dissecting way to take apart the case and to put it in those details. So I need for specificity. I need for you to match that. And that is really the nature of the assignment. So again, before I close, I think we can be a great community of support here by talking about questions that we have and posting those questions in the discussion section of Blackboard. But do not talk about the assignment, okay? If we are clear about these unipolars and we are clear about the 3 types of bipolars, you will all hit a home run in terms of making the specific changes. I understand these are different words and it can be confusing. I hope that you will view this video at least 3 times. Slow it down, look at the notes that I've given you, take other notes on those notes, and if you have a question, post it. But don't post, I don't get these depression issues. Try to be as specific as possible so that as a community we can help clarify. Okay? So I want to be there for you. I want to make this material make sense for you because, frankly, all of you will be touched by individuals important to you who deal with depression and bipolar issues. So knowledge is power, whether you decide to be a clinician or not, to make you a more educated consumer that can help somebody else to recognize that they have symptoms that would warrant them following up with a therapist and learning more about it. You don't have the skill in this class to tell somebody, oh, I think you have bipolar 1. You do have the skills, if you know this person, to see that they're acting in a fashion that fits some of these symptoms and that you can say, I'm concerned about you. I'm not well versed enough to give you a diagnosis, but it would make me feel so much better if you would go and check this out with somebody who's more knowledgeable. Going to a therapist does not mean you are crazy. It means that something is not going well in terms of the distress, which is the amount of symptoms that you're experiencing, which impact your relationships, your work, your parenting, your everyday functioning, maybe in terms of your ability to get out of bed, your ability to shower and take care of your ADLs. So we want you to be free of some of that. And therapy, short duration, can be very helpful in assisting with that. Some of you might be actually asked and discussed with in terms of taking medicine. Don't be high and mighty. I'm never ever going to take medicine. In this world, you can't ever say you're never going to do anything. You don't know what your circumstances are. but a therapist will partner with you. Nobody makes anybody do anything that they're not comfortable doing. But again, my job as your teacher, as your clinician, is to work with you to give you the tools to make you informed. It's okay to have opinions, but opinions are not what rules the day with clinicians. Clinicians need to stick to the symptoms and get clarity with the client that they're working with, and with our friends, express concern and get them to the next step and tell them that's just a smart, intelligent thing to do. Doesn't mean that you're telling them that they're crazy or that they can't deal with certain things. It's like, why wouldn't you get more clarity about this? Okay, so I look forward to your posts. You now are ready, as far as I'm concerned, to play this back many times and get ready to start to write your responses. Remember, you are only sending your responses to me at lizreis@aol.com. And here we go, folks. Take care. Be well.